tonight it's a deadly virus with a rather sexy name, Marburg. That is devastating. Don't let the name fool you. If you read the literature, and the BBC reports this, that is in the same family as Ebola. So it's a very, very deadly disease indeed. What do we know about it? There is an outbreak of it in Ghana. The thing is, although it's that deadly, we are not talking about it enough. We're doing a lot of things, talking about politics, the economy, obviously, but we're not talking about the thing that will kill you. I mean, I know people are hungry because the economy is in a bad shape, but at least, I mean, you'll survive longer. But this one, it's almost a death sentence, almost a death sentence. We'll talk about the fatality rate pretty shortly when I speak with my experts. And that is why tonight I wanted to devote an hour to talk about it. If you haven't heard, and we went to the streets today asking, people don't know what it is. They don't know what Mavic is. They know Corona. They've heard about Ebola, but they haven't heard Mavic. When you say Ebola, people panic, right? Maybe we should tell them that this is the same. So maybe we all start taking this pretty seriously. We'll look at the differences there and the similarities to that. When you give people a comparison to something they know of, that gets them to move. But when they've had Marburg, you probably would think, I joked today, Marburg sounds like a name of a town in Johannesburg. Or as somebody had said today, a fancy name for a new car, the new Mercedes Mavic, you know, but it's deadly. So two cases so far, 2 people dead within hours of getting the virus. From what we know from the Ghana Health Service, they had developed symptoms, and then 24, 48 hours later they were dead. That's how deadly it is, right? And this is what we know in terms of what the Ghana Health Service has provided so far. The preliminary findings, 7th July, the Noguchi confirmed that this is Marburg. The corroboration of the results was sent then to Dakar, Senegal. They corroborated it is Marburg. You know why they sent it there? We haven't recorded it before. I mean, it's so deadly when you see it. You see it, but you want to be sure. Like, it can't be it, right? It can't be. So just send it here as international protocol says. Someone else must give a second opinion. And then it came back that it is in fact what it is, that we may be in some trouble here. But the Ghana Health Service moved into action and they started contact tracing. So they found 98 people who may be exposed. And so in Ashanti and Savannah, they put them in quarantine. They were monitoring them to see, will they develop symptoms or will they not develop symptoms? And we'll speak to the Ghana Health Service for an update on those in quarantine so far. So what is it? Well, we know it's a rare but very severe hemorrhagic fever that affects both humans and non-humans. Primitives and fruit bats are a natural host of Marburg virus. Now, the thing about this, you remember where it came from, the first 2 people in the Ashanti region, bats. We like bush meat. You know about dankwansere. It's a delicacy in some communities, but it can kill you if the bat has, the virus sitting in it. And that's why, the Ghana Health Service is asking us to be pretty wary of bush meat. The mode of transmission through people from animals to spread among humans, through human-to-human transmission from direct contact with body fluids, blood, other discharges from affected person and animals. We'll get more about it. This is just a basic what we know on the surface, just helping us get to the heart of this. And then, for me, the thing that really got me when I was reading this is the symptoms that you show when it comes to the Marburg disease. And the Ghana Health Service gave us a breakdown of the symptoms. And I want to show you the symptoms. And this is what really got me to discuss this, because I'm like, wow, are these the symptoms? And why are we not talking about it? Fever, that you say, yeah, it's okay, but the rest, shocking. Bloody diarrhea. You'll be pooing blood. Think about it. Bleeding from gums, you're bleeding from it. Bleeding into the skin. I don't even know how that is, what that looks like. You're bleeding into the skin. What does that? I mean, I have a picture of it in my head, but I can't imagine it exactly. Bleeding into the skin, bleeding into the eyes. It almost looks like a zombie apocalyptic movie you watch, right? People bleeding into the eye. Bloody urine, so you urinate in blood. That is a terrible way to die. But that's what the Marburg disease is. And I told you, don't be fooled by the name. It's a very, very deadly disease. I'm like, why are we not making noise about this so people know, so we can all stay safe together? One of the lessons I learned from Corona, when it first started, they said, oh, don't cause panic. And then people eventually go and say that, but I don't see anybody dying. By the time we realized that it's actually killing people, it was a lot of people who were dead already. If we started by getting people to appreciate the reality of what it was, maybe people would have taken it more seriously. And we don't want to repeat that mistake by just taking it and say, we don't want people to panic. So, and people will go about doing everything like, business as usual. This is not business as usual. It shouldn't be. And let's educate ourselves a bit more. So today I have experts who will help us. What is the prevention? From what we know, avoid exposure to, the mines or covers inhabited by fruit bats. So note that, please. Thoroughly check all animal products before cooking and consumption. It is here in Ghana, so please, this is important. The World Health Organization, this is so critical that the WHO is stepping in. That in the coming days, they'll send a team of experts to assist Ghana fight the outbreak of the Mavic virus disease in the country. If it was something that we could deal with, WHO would not have to step in. But they have to, because this is one of those very deadly ones. The support that we are getting from the WHO will get coordination, risk assessment, infection prevention measures. They will give us that on this. And so this is the very basic that we know about this. I have assembled a team of experts who understand this to help with the education tonight. What is it, what is not, how you get it, how you prevent it, all that, so we can all stay safe. And my guests are joining me, and that's the General Secretary of the Ghana Medical Association, Titus Bayo. Also joining me is the Ghana Health Services, I say to Bekwing. I say to Bekwing, Doc, is that Manchester United jersey you're wearing?
It's red.
Kotoko. Okay, yes, okay. Oh, I'm good to know it's Kotoko. I see his friend from Ashanti region is smiling very broadly. He likes the two of them from Ashanti region. I'm very excited by somebody wearing Kotoko. Listen, I have guests who are joining me.
This is Manchester by Kotoko.
Ah, okay. Well, I'm with you on that because I'm a staunch supporter. I'm sure you've been watching the games in the preseason. You might be excited. Listen, no, not let's talk about that. I mean, don't get me started on that. Let's talk about Marburg. After the break, we'll get into the details. Stay with me. Joining me for the conversation tonight is Director of Public Health of the Ghana Health Service, Dr. Franklin Asiedu Bekwing. Also joining me is the Ghana Medical Association's General Secretary, Dr. Titus Bayo. Dr. John Amoisi is a public health expert with the KCCR and lecturer KNUST. He became a household name, obviously, here on PM Express on the multimedia group when Corona hit. In the studio with me is Dr. Banda Khalifa, is a global health expert and the health advisor, Tony Blair Institute for Global Change. Dr. Michael Owusu is virologist with the KCCL2 and a lecturer at the KNUSC as well. Dr. Asiedu Bekwing, let me start with you. The individuals you had in quarantine, what's your status now? What's the update on them? Are they all fine? Please unmute for me.
Yes, thank you very much, and good evening to your viewers. I need to state that when it comes to a condition like Ebola or Marburg, it's about identifying the contacts. That's most important. So as much as we are concerned, if you're able to identify 98 contacts, that is not all the contacts. Because if you look at the trajectory, it's like 34, you go to 63, now we are 98. I'm sure we'll still get more contacts. So don't get surprised when we get more contacts tomorrow, because we are exploring to be sure that where did these people go, so that we can be able to establish. But for now, we have 98. 50 are from Ashanti region, and 48 are from Solar to Nakaba. So the 50 from Ashanti, based on our 21-day maximum incubation period, they have covered. So you can say that they have been discharged.
Okay.
So now we are looking at the 48 in Solar to Nakaba. So that is the status now. And I think that we will continue to monitor to be sure that we don't miss any possible contact, because that may be a source of transmission.
Okay. So would you say that we have it under control now?
I think that what we do is that when you talk about contact trace, it's about following them up on a daily basis, trying to ascertain their clinical state. And there's some evidence that you try to do temperature monitoring. So for the 98, I think that the ones that were in Ashanti, they've been shown. Let me say that it was only one health worker that showed symptoms. So they took sample and was sent to Noguchi. That was negative. Then I think we did something which was not a typical. Normally you take samples when you start showing symptoms, but we try to randomly select some of the contacts. And we took samples as negative. But I think that it's a period. So for now, they are stable and we are monitoring them.
Okay. And then very finally, before I bring in the other guest, do we know the actual source of this, how this got into the country?
No, you see, so I think that, as I said, we're still investigating. So you see, if you look at the first case, which we call the index case, it's like came from Western region. So the idea is that which part of Western region is it coming from? And initially it was like Bok was always a big place. So we are trying to draw down to a smaller community, and then we'll get an idea. But so for now, we are not very certain. And let me say that trying to ascertain the source, we are working with wildlife division, because it's a zoonotic condition, so they will have an idea where is it coming from. But I will say that for now, it's not clear the source of the outbreak.
I mean, Dr. Khalifa, how important is that in the process of trying to get this under control? Finding, patient zero, but also drawing back to where did he get it from?
Yeah, so good evening to your listeners, and good evening to my senior colleagues. I think that in public health response, if you really want to break the chain of transmission, then you need to identify the index case, or at least know the source of the infection. And in this case, it could either be from wildlife to human or from human to human. We'll be more worried if there is a human-to-human transmission, and the cases we are recording are not the index cases. So in that case, we assume the index case is still at large. That would be a serious situation. But in this case, if it's just from wildlife, maybe from bats, or if the person has visited caves, or he's a miner or something that prolongedly expose himself to those sources, then that probably might be the source of the infection. And in that case, then we've been able to identify the two index cases, and that wouldn't be a concern for.
In that case, once you identify that latter scenario, you just deal with the human being with it,
yes,
and hope that, of course, and look at his contacts.
His contacts, exactly.
Exactly. Which is what they've done now, with the possibility that they could find more. Let me bring in Dr. Titus Bayo, the doctors now. As we just heard there, a health worker was exposed, showed symptoms, but it turned negative. I'm pretty sure that you are an integral part of the surveillance group now that is looking out for this. I wonder how the health workers are dealing with this outbreak. Is it, we went to the street, people just didn't even know what it is. But among health professionals in Ghana, is this widely understood what this is and what to look out for and the protocols to trigger if indeed you suspect a case in your hospital?
Good evening, Evans, and good evening to co-panelists and to our viewers. Yes, indeed, clinicians are properly briefed and well informed about the case definition because immediately this case came up, in fact, the Ghana Health Service had circulated the case definition to all clinicians. But I would want to start by commending the frontline health workers or first responders who attended to these cases and commend their professionalism and high index of suspicion. So I commend my colleagues who were directly involved because at the time, we had never had this case in the country. And so it needed to take some level of index of suspicion to even pick it up. To the extent that upon the diagnosis, we haven't had several health workers infected, also means that standard infection prevention and control measures were heeded to by our clinicians and other cadre of healthcare workers that attended to these two patients. And that is why we haven't had a mass outbreak among the healthcare workers. And we are getting good report that most of them are doing pretty well. And also, it also speaks to the fact that we have been prepped as a nation because during Ebola, we put in a lot of measures. We send workers to neighboring countries to assist, and we never had a condition in Ghana. COVID came, and we are still in COVID, and I think COVID has done us a lot of good in this sense because it's put everybody in awareness and increased our adherence to our standard infection prevention protocols. I dare say that if there wasn't COVID before this supposed outbreak, we never know what might have happened because people might have taken things very lightly. So I think I'm pretty confident that should any of these contacts appear anywhere today, or somebody else who has not been picked up appear in any clinic today, the clinicians are well able to pick up the patient by the case definition to prevent further spread. Okay,
let me bring in virologists. You talk about case definition. Dr. Michael, what is it exactly, Marburg? And what is the case definition? Well, what is it? The name sounds very deceptive, but from everything I've read, it's a very deadly one. I mean, give us a sense of what this is from a biological point of view.
Yeah, Evans, good evening once again, and to all colleagues, professionals. So, I mean, if you're a virologist, viruses that you don't want to, you'll be reluctant to work on are what we call the viral hemorrhagic fever viruses. And Marburg is one, Ebola is another, and then Lassa fever, and then Crimean Congo hemorrhagic fever viruses. So these four viruses have classical symptoms and signs. Start with fever, body weakness, and the overt symptoms are bleeding through the nose, bleeding through the mouth, and then passing down bloody stool. And because we know it's highly, highly infectious, if you have followed through the outbreaks of these hemorrhagic fever viruses, if it's not from animal, then it's from the laboratory. So sometimes in the process of working in the lab, either on human or animal tissue, you tend to expose yourself. It is why, I mean, I'll join Dr. Titus Beale, not just for the clinician, but then the laboratory personnel who also did the test and was able to identify this and never missed it. I mean, the group has done well. So Noguchi as well, I mean, must be congratulated. But then if you talk about Marburg, I mean, I want to take you back to what we used to know. I believe strongly that this may be of possible zoonotic origin, and not likely from an imported case. Because of what we do and what I have done.
Sorry, you use a technical term, zoological origin, you mean from an animal?
Exactly, okay. Exactly. So because if you remember, somewhere in 2011, Ashanti region had 2 cases of Lassa fever that these people died in Aman's West. And further investigation showed that these viruses were found in rodents, which were in those communities. And that was the first red light that people saw. And then people have done studies somewhere in 2010 where they have screened about 262 bats in Accra and then in Kumasi, and have found antibodies to Ebola and then antibodies to Marburg.
Okay.
It traced this back. I mean, even the very first case of monkeypox in the US was traced to over 800 animals, squirrels that were sent from Ghana and processed in the US, through which we had, some of the cases that we are recording. We have also joined a number of studies. We have screened bats like Rossettus bats, Eidolon bats, Hipposideros bats, many bats living in different places. If you don't find the RNA in the stool of these bats, you may find that they have antibodies to some of these animals.
Which means that they may have been infected before and recovered.
Exactly, okay. Exactly. So these viruses, I believe, are sitting in this wildlife, only waiting for an opportunity to get into the human population, which is why we always will have to be very careful. Most at times, if you look at the Lassa fever case, these were farmers and also hunters who had gone to do their own thing, and through their activities have brought this back. So, the first speaker was talking about dealing with it from human to human transmission, what is good, which is what we are mostly doing, trying to look out for the contacts, tracing, and then identify index cases and do all we have to do, which is excellent. But also, it is important not to just overlook the zoonotic source of this, because if you deal with the human-to-human transmission and you don't deal with the origin of this, there will be what we call a spillover effect. You may finish doing with the human-to-human phase, but you're only waiting for another time for the animal source to be reintroduced into the population. And this is going to be a long, winding years upon years upon years. If you know that within this community, it is a Rossettus bat sitting somewhere that is carrying this virus, then you know how to target your intervention. You can educate the people well to avoid some particular species of animal, and you can classify this within your region, and it helps you. In the case of SARS coronavirus 2003, it was when they were able to identify that this was from palm civets or raccoon dogs, that they were able to target their intervention and just close it once and for all. So all the two phases are important. And although it's quite expensive to search for viruses in animals, it is also useful. So that you can understand what we have and what is circulating, what is sitting where, advise people on what to do, what to eat, what not to eat, and then how to manage themselves as a people. In Ashanti region, we are highly dependent on things like bushmeat. Most at times if you go to the restaurants, people take all sort of bushmeat, even to the point of sometimes what we call fecal matter from bush animals. They call it ochibi and all that. People fancy a lot of things from these animals. And the more we do that and the more we depend on this, it also exposes us. We create a huge market for these bush animals, but then the effect is what we are seeing. So I think this is a wider conversation for us to not just to look at this as an outbreak and a public health response, but then to throw the net wide and to begin to understand what is sitting somewhere, so that we'll be able to plan over long-term years to take action even before these viruses and these things even get into the population.
Dr. John Amoisi, how deadly is the Marburg virus?
Well, thanks, Evans, and greetings to everyone who's listening tonight. I think it's great that we can have this discussion, and all the previous speakers have really elucidated on many of the points and brought to light how important this virus is. It's really important to put things in perspective, because this virus is very deadly. But the question is, how does it spread and what is the risk that we face? If you ask me very candidly right now where we sit, I would say there is no cause for alarm.
Okay.
And I say there's no cause for alarm for two reasons. If you look at the history of the disease in itself, and you look at when the last outbreaks have been, most recently in Guinea, and this was the same town which brought forth Ebola, the town of Wikadu in Guinea. They had just one case of Marburg virus, and that was it. This was in 2021. Before then, there had been cases in Uganda, and actually Uganda is the country that has had the most outbreaks. And it's been a handful of people with sometimes 50% mortality, sometimes 100% mortality. But if you look at the 100% mortality, it's those outbreaks that have been 1 person, 2 persons, maximum 3 persons. So it is very deadly. but it's not that easy to get. And this is why I must again join the other speakers in really congratulating, in particular, the team in the district at the Dancing North and the teams at the hospital that have this index of suspicion. And it's really gratifying and refreshing to see how our public health system is able to do all the right things. If you ask me very candidly, I think we're doing pretty well. I honestly don't know what more WHO will come in and add to us. We're very happy to have them support, but we've checked all the boxes. Every single box has been checked. And it's very interesting. If you dive deep into the research, you'd realize that Marburg has been with us for quite a while. If you check the literature, you'd realize that there has been evidence of people carrying antibodies to Marburg. So that means that it's been in the system somewhere, but we just haven't had a confirmed case of Marburg before. And it took the high index of suspicion from public health workers and from clinicians to say, let's take a sample because this looks like a viral hemorrhagic fever. We've got to look into it. And then we got the result that we needed. The good thing is that as many contacts as possible are being traced. And so far, nobody has gotten sick. The one health worker who was suspected, actually that bleeding or whatever was in no way related to Marburg, it turns out. And I can say this on authority because I actually was on the ground at that district, at that hospital. I inquired directly myself. And you look at the way with the history was taken, the information was relayed through to authorities in Accra and then on to the WHO. I mean, really, really beautiful. I mean, just to say the least. The transparency with the information has been passed on to the international authorities, highly commendable. So far, as I said, no one in quarantine has been ill. Similar things happen if you look at the history. In the Netherlands, they had a case of Marburg, which originated from Uganda, interestingly. They followed up 130 people, close contacts, nobody got ill at all. So it's not surprising that nobody has gotten sick, even though there were contacts. And Dr. Siedu Bequin rightly pointed out that they're trying to round up and get everybody. So yes, very deadly, but it also takes quite a lot to get it. But because of how deadly it is, you don't want to get it, because if you do, then your chances of dying are pretty high. Yeah. So pretty much the same things that you do for Ebola is what you do to prevent Marburg. And I would say that we're definitely on the right track right now. And I'm hopeful that if after this 21-day period, nobody gets sick, then we could largely say that we're out of the woods. And if by the end of July, nobody gets sick, I'm sure WHO will declare that this outbreak is over. And this is what we really hope will happen. Yeah. Very interesting. Dr. Clay, what do you say to that?
Yes, I think he's made quite important points. Even though our intention is to educate the public, it's also very crucial not to sound a panic alarm, because as he rightly said, the case fatality.
I like when you talk to experts. I had a fantastic talking to experts, but me as an ordinary person, when I heard it and I read the symptoms, I was alarmed.
Yes.
I'm so very calming hearing all of you say, don't panic.
Yes, I think it's very important to stress that, because he also did mention that the mode of transmission is such that you have to be in direct contact with someone who's infected.
I've heard that a lot. What is direct contact? Define it for me.
Okay, so direct contact means that you come in close proximity with substances that are infectious.
Would this distance qualify?
Not at all.
Okay.
So you have to be in direct contact with fluids that are known to contain the virulent agent. So for example, if somebody's bleeding, there's blood. If you touch the blood and you have exposed skin surfaces, you could get infected. If somebody, let's say urine or saliva or...
Oh, so you can get it through saliva?
Yes, and in some cases, even in semen. So these are when you come directly in contact with them. And then the materials that the person might have used, so maybe the bed sheets and all those things, if there are fluids on it and you touch it, it's most likely you'll get infected. But until you get directly in contact with those things, you are not at risk. So as Dr. Titus rightly said, the most important point, if you take out the zoonotic origin, it's the healthcare workers, those who have a high index of suspicion, those who are able to diagnose this are usually at higher risk of getting the infection. Of course, those who are able to handle these samples, because samples from these patients are usually classified as biohazard level 4.
So let me ask you, can I get it if, say, we are sitting here and say you cough and can I breathe it in? Can I get it through that?
Yeah, so classically, we don't say it's airborne.
Okay.
Right, so Marburg, Ebola, and the other hemorrhagic fevers are not classically airborne infections. So the probability of you getting it if you're sitting across, it's very unlikely.
But if it settles on the surface,
yes,
and I touch it,
most likely,
and I rub my eye,
exactly, mucous membrane,
I will get it.
You can get it.
Okay.
Yes, you can get it.
Okay.
So it's deadly. Yeah, it's maybe from 27 up to 88% mortality. So currently in Ghana, we will say our case fatality rate is 100%. But
for the two who got it,
yes,
or the two we know who had it,
have died. But technically, it's not that easily transmissible. So
okay.
It's not as bad as it is. But I must also commend the public health division for the prompt response, because we all know the immense strain that they are in. Currently, they are responding to monkeypox, COVID-19, and now Mavic. And it's the same health personnel who are dealing with these contact tracing and all that. So I must recommend them for doing a great job.
I mean, Dr. Seydou Bekwing, so great that it's direct contact, very difficult to get it. But from everything I just heard from Dr. Khalifa, you can still get it if it's on your surface, you touch it, and the same coronavirus, transmission thing, up with the exception of the air, right? So I wonder, should we go back to, the washing of hands? I mean, many have dismantled their Veronica buckets, and the hand sanitizers, etc., the face mask is all gone. What is the public health advice that the Ghana Health Service is giving? Let's do that now, because I think that is very critical. Now that we know it's difficult, I mean, no cause for alarm. So, should I just go about my life as normal?
Thank you very much. So I don't think we should just do things as usual. Because if you are not lucky and you get the disease, fatality is very high. So there's one very cost-effective intervention, that's hand washing. I mean, it cuts across whether it's in influenza, whether it's Marburg, A3N2. There are a lot of them. So I think that this issue about hand washing, particularly with soap and running water, is a very good intervention. If you look at this Mavic, it's about contact. So, we stopped shaking hands when we had this COVID. And I think that now we have started.
Yes.
We have to go back to stop, because it's about direct contact. So I think that when you have a disease like Marburg, that hugging, shaking of hands, I mean, which things that we should not encourage. So I think that I want us to just link the COVID response actions to Marburg, to influenza, to monkeypox. They are about the same. But you see, I think one thing that is a bit different about COVID and Marburg is that for COVID, the person who is asymptomatic can spread the infection. But that's why you need to be symptomatic. So I think that's the difference. So that's how come maybe the rate of transmission is a bit minimal. But the issue is avoiding contact. And it's very, very important for us to stress on it. That for now, for this particular outbreak, as was said, we are not sure about the source. So in that case, we need to look at the zoonotic part, the animal part, and also the human part. So which animals are involved here? The common reservoir is the fruit-eating bat. So how do we avoid this one? And it's about avoiding it's not just the eating, it's the handling. So because before you can chew the bat, you have to kill it and involve getting in touch with the secretions and blood. So that is one big thing. So I think that's one thing that we want to put across. One thing that I also want to put across is about burial.
Burial.
You see, yes, is one thing which is a big bane in our system. It has its own religious issues. People die you're not sure of the cause of death. Within a matter of hours, you're supposed to bury. And then there are a lot of exposures that come. So for this era that we are in, I think that barrier will give a different dimension. We are not going to allow people to bury by people within 24 hours as it has been, because they're not sure of the cause of death. Particularly, the person has been oozing blood or other secretions. So I think that that's one area that we're going to have a good eye about barrier, because one main thing that was causing a lot of the infections in the Ebola period. So that's one thing that I want to put across, that when your relative is dead, you're going to have challenges releasing the bodies to you as early as possible, as was happening in the time past. But for this outbreak, for now, it's early days yet, but I think that it's being managed as a kind of a localized outbreak. So the issue is about, we call it containment at source. We don't want to spill over to other places. So that's the dimension. So if you look at the interventions, people are complaining that they're not hearing of this in Accra, because it's like the focus is managed at the source. It doesn't get global. I mean, it doesn't get nationwide. So that's why maybe people in Accra are not hearing about it. But the issue is make sure that it doesn't move out from that place to other places. Hopefully, we have another stage which is across nationwide. So in that case, all the interventions go across. But for now, let's contain it at source.
Would you advise for now that we stay off bush meat generally?
No, you see, this bush meat issue, I think that, you see, it's not the eating of the bush meat, it's the preparation of the bush meat which is the issue. Do you understand? So if the bush meat is well done, I mean, I don't think, but it's the handling of the bush. The person who is preparing the bush meat who is more at risk than the eating. So I think that for now, I'll say that for the bat, we can do away with the bat, because I mean, this is the main reservoir for Marburg. But for the others, I won't prescribe fully that don't go, but it's the handling of the bush, which for me is the focus. Okay,
so just clarify. If it is handled, if it's cooked, then you are safe to eat. Is that the general?
If it's cooked, I think that my biologists are here. If it's cooked and well cooked, I don't think the risk is there.
Okay.
Is the preparation of the meat which is a problem. Because when it's well cooked and well cooked at like 100 degrees Celsius, I mean, I don't know which virus is going to live there. So I think that decision must be made clear. So it's not just that the meat, which is the preparation of the meat being exposed to the secretions and the blood, which causes the infection.
Okay, let me bring in the virologist in this. What do you say to this in terms of advising the public when it comes to bushmeat, Dr. Michael Owusu? And I'll come to you, Dr. Jonomwit. I know you had something to say about the source question. But Dr. Michael Owusu, on that question, on the bushmeat.
Yeah, so Evans, bushmeat is a delicacy and it's food as well. And when
I like the way anytime you talk about bush, smile. You must be a lover of bushmeat yourself.
Whenever you are dealing with pandemics of this nature, you need to keep a balance.
Okay.
You cannot break some bushmeat and say that people should not take bushmeat. People will go hungry. It's a source of protein, and I mean most people depend on this. But where do you put in the balance? You need to look at the in order of priority. Animals that are high risk. I mean, there is the bats, which are mostly likely to carry this. So if you have to put in any restriction, I think you are better off putting restriction on the bat. And the point is that yes, if you cook the any bush meat and you eat, those eating will not have a problem. But then eating means that you create the market for those who hunt and process it. And this is how you look at it in the bigger context. Okay. So if people are eating bats and you tell them that, look, limit or stop eating bat at this time, those who catch or hunt for this bat will not do that. They will switch to other animals that are less riskier. So you are looking at those eating and then those supplying. And if you want to give the supplier, then of course you advise those eating to limit it, and those supplying will actually manage. So I want to go with that. I think we have to manage this step by step, and not just put more of a big hammer and say that, look, then stop. We are not there yet. I think that for now, the focus must be on the parts which literature supports that this is indeed what is likely to be the source. But then I believe that as data emerges, If things stay as they are fine. But then if things begin to go the other way, I'm sure we have to expand and begin to look at other rodents and grass cutter and other families, and then see if we could add this together. But I want to go with the back.
So you're saying from an expert virological point of view, it's safe now to say ban the eating and handling of bats?
I would go for that. And I think that it's very, very helpful that we put brakes on bats for now.
Okay, and is bats what we call in Chi dankwansere? Is that the bat? Is bats?
Yes, others, I don't know, but some tribes call it dankwansere, others call it ampine.
Okay.
Ampine dankwa. This is how different tribes call it.
Yeah, because I've been in Kumasi before. You go to a chop bar by the roadside, and dankwansere is a very popular delicacy. I mean, you mentioned it, and it has a way of being, when you cook it, it sucks the soup into its stomach or something. You press it. So there's a whole custom around eating it.
That comes out. Some call it feobo. Feobo means that
feobo, exactly.
And that is what people really like. So it's good. It's good to let people understand something.
But that is very important. So if you're watching us tonight and you like it and it's a delicacy, that is the expert advice. Stay away from bats for now and allow the Ghana Health Service, as you've had explained, trace and track and deal with this, because you may not know. But the instruction is, if it's cooked, you can eat. But of course, when you do that, then you're encouraging, the market for its handling, which then exposes people to it. But let me bring in Dr. Amoy. Dr. Amoy, you had something to say on earlier.
No, that's right. And I think also on one of the issues you just touched on, it's, not so much the eating of the bats themselves, because by the time it's really cooked, the virus will be totally killed. But indeed, the consumption encourages the catching and the handling, and that's where the problem is. I mean, these bats are really amazing animals in terms of the kinds of viruses they can inhabit. But this outbreak really leaves a lot of questions unanswered, which I think are interesting and useful for us to sort of pick certain cues from. We had two cases originating from, a district in the Ashanti region. The two people are completely unrelated. Dr. Asiedu made mention of one having had a history of travel to the Western region. But the argument is, what is the probability that somebody who came from the Western region and then somebody who was in the Ashanti region would all converge at the same point with a Marburg disease? So if you ask me, analyzing the situation, it would seem more to have originated from one place. But these two individuals are completely unrelated. So at what point in time did they come into contact either with each other or with a singular source? And given the time at which they got sick and the time which they died, it suggests that the time of infection was just about the same. Of course, the incubation period for this disease is quite wide, from anything from 2 to 21 days. So there are a number of pieces of the puzzle which are present and some which are absent. And I think the picture is still being drawn. Now, the important thing here is when the picture is clear, it helps us to target where to go to look. Because if we conclude that this originated in a particular district in the Ashanti region, then we know that maybe that's where we need to focus our attention versus in the Western region and so on. Not to speak of the contact tracing of people who've come into contact with these people. Obviously, I think it's very clear that the origin would have been from some animal of some sorts. And if you know that district, it's really surrounded by, it's very forested. All around it's just forest, and it's just the road between, Kumasi, or should I say Bakwai and the Asin area, and it's just all forest. And they do a lot of bushmeat stuff. So it's not surprising at all. But it's just interesting how two people got sick around about the same time and died, and they have no contact with each other. So I think a lot of questions to ask, very interesting from a research standpoint, which can inform our public health actions. And this is the beauty of the research part of it, where we're able to answer questions. It's like detective work, where you say, okay, you put two and two together, therefore it must be this, and so let's do that. It can help you to save your resource, to save your time, and be more surgical about your interventions. And I'm just happy about the way we're able to work very closely with the Ghana Health Service and with other stakeholders to provide some of the answers or provide some of the pieces of the puzzle. So I would say so far, so very good. And if we keep it clean for the next week or two, then I'm sure this outbreak will be declared over. And so fingers crossed, prayers going on, and hopeful that it will stay quiet and we can declare this over.
Dr. Titus Bayo, frontline health workers, are you equipped with the resources to deal with this? What I mean is PPEs, special treatment wards, etc., in the wake of this outbreak?
Well, for the nature of this present outbreak, I don't think we have inadequacies. Coming on the backdrop of COVID and the distribution of PPEs and all the things that we need to fight COVID, a lot of them are still very useful to fight this outbreak. And considering that this is not like a nationwide outbreak, I think we are adequately equipped to handle any outbreaks, sporadic outbreaks like this. I am informed that the place were a bit challenged with isolation, and it just tells us the nature of the situation, because these outbreaks can be very sporadic and they can appear everywhere. And you cannot get a high-level isolation system everywhere in the country. So it is a reason why that index of suspicion is needed. The adherence to standard protocols are needed, so that even if this appears in a smaller clinic somewhere, the health staff should be able to identify the risk that it poses, isolate within the level of the care that they have, and then alert the system to be able to create a proper isolation system for such a case. And I think that was beautifully done in this situation. So I would say that we are well prepared. But I would want to quickly add on that while we are encouraging clinicians to keep a high index of suspicion for cases like this and other infectious diseases, we also need to look at the community level. I think Dr. Asidu Bekin mentioned the issue of barrier. And I want to use this opportunity to really appeal to the communities, because I know the extent of pressure that my colleagues face when there is a death in some communities and doctors are not sure why the patient has died. They wish they could investigate a bit further, and then there will be pressure, release our body, we need to bury within a certain stipulated period of time, and sometimes even how they move their body without the necessary, because in one of these cases, I am informed at some point they thought it was an upper GI bleeding, bleeding from the upper gastrointestinal system. So if at that level, they are not sure, they want to take samples, and the relatives insist we want to carry our body away, that is a lot of exposure to the family and everybody else surrounded of it. They may not have even gone for, in some instances, people just take a pickup and pick their body and they are off to go and do their burial. It's not an ambulance, it's not a hearse, there's no proper, even those handling their body. So I think all of us need to be careful at that level. My next level to the community will be that let's let this index of suspicion move from the hospital to the community, because at this point, there are contacts we may not know. And since we are not sure how these patients got the infection, it means somebody else could get it from another zoonotic source somewhere else. So if somebody has bleeding tendencies, some of the symptoms we've mentioned, they are very vague symptoms, because fever, almost every disease in Ghana gives fever. Most of our infectious diseases, malaria, typhoid, they all give fever. There are other bleeding conditions that can occur. So if you just put 2 and 2 together, these could pretty much represent several other diseases. Now, one of the things that happened, one of the lessons we learned from Ebola, which I think we must be careful of, is that a lot of people died during Ebola from non-Ebola diseases just because they were bleeding. And once that fear and panic is created, even a woman who has abnormal uterine bleeding gets to the hospital and everybody's afraid to touch. I want us to allay that kind of fear and tell clinicians, as long as you are using your personal protective equipment, you are using your gloves, there's no cause for alarm. People have handled these 2 cases and they haven't died yet. So please don't run away from the next bleeding case that comes before you. Don't run away from the patient who comes before you with an epistaxis or bleeding from the nose. And in the community, if you see such a patient, please get the person to the hospital. But while doing so, don't handle this blood or secretions from their body, so that we can all remain vigilant. I think
Okay.
that is the advice I would give.
And very finally, I'll come back to wrap up in the studio. But Dr. Sidibequin, that last point, one of the points that Dr. Titus Bayo raised about, and you touched on too, how are you enforcing this releasing of the bodies to the families? The need to keep it for investigation before you release. That is always going to be a difficult one. How are we enforcing that?
Yeah, so thank you very much. I think that we're going to work strictly with the local government to ensure that all the private funeral homes and all those things are well kept in check. I mean, we need to have a clear birth certificate, a burial certificate before bodies are released. So I think that this is an opportunity for us to actually put in strict measures on the release of bodies. The time passed, I think that they have not been very strict, but we're going to work with the local government, environmental health, to ensure that this is done. But let me say before I go off that, I think that what is going on tells you that the Ghana public health system is intact. We have our own challenges, but clearly ability to detect is a key. Detect and respond, because if you don't detect early, you overwhelm. So and let me say that it's not just at the national level, the regional level, the district, Ashanti region. So good, despite all the challenges, they are doing their best. And let me also add that we are doing this together with the partners. So with the CDC, WHO, FDCO, UNICEF, they are all together, they are fighting together. So it's not that there's a team coming from somewhere coming to address any problem for us. I think that thing should be off. We are doing it from Ghana, and they are part of the team. And I want to stress that one. So it's not that Ghanaians are sitting there sleeping, and some people come from above to do something for us. No, that's not the issue.
Great. Dr. Kali, that's a very important point, because I was going to end with that, because you, of course, are the global health expert, health advisor. I mean, nowadays, because of Corona, anywhere in the world where something like this happens, almost the whole world reacts to it very quickly. So this was expected, isn't it? That the World Health Organization, everybody also mobilized to come in.
Yeah, so I think that with increasing urbanization and technological advancements, international travels and all that, when a disease of this nature pops up somewhere, because of its sudden nature, it's been relatively rare, the international body usually react in some way just to make sure that it is really contained, because so far we've had 6 cases of diseases that are of public health concern, international concern.
I mean, since Ebola, since coronavirus came, there's been
so coronavirus
is part of,
yes, the Zika and the rest. So we want to make sure that we never get there because of the potential public health implications. And as Dr. Sidibequin said, I think Ghana has done really well. Our public health infrastructure, even though it's a bit deficient, we are doing a great job because I think in 2021 there was this index that they revised, the Global Health Security Index, and in the component of early detection of viruses of pandemic potential or epidemic potential, our percentage point increased by 10. So that is a really good point there. So I think that as we've all discussed, it's not to sound the alarm, but we have to look out for. And one plea that I would also want to give the Islamic community, I've worked in the clinic before, usually when someone passes on as a Muslim, the families,
very quickly, yes,
the families want to rush and bury a person. So it's very important to engage the people at the community level, let them understand what we are dealing with, so that in case a family member or a relative suddenly becomes ill and having complications, they will have the patience for the health workers to deal with it in an appropriate way.
Thank you, Dr. Banda Khalifa, Dr. John Amoisi, Dr. Titus Bayo, Dr. Michael Owusu. I'm grateful. Don't panic, but be vigilant. Enjoy the rest of your evening.